Hello, and thank you for taking the time out of your evening to join us for this same-sex male pathways to parenthood webinar with Dr. Tom Bamford. Following the presentation, Dr. Bamford will be responding to your questions. You can submit these at any time during this evening's webinar via the Q&A panel on the right-hand side of your screen. I'll now hand over to Dr. Tom Bamford.
Thanks, Sam. So lovely to have you all. So really today will just be kind of a very brief overview into what's involved in starting a family, particularly focused on same-sex male couples, or those assigned male at birth. In particular, it might be relevant for those couples, for example, patients that have transitioned. So essentially focusing on patients that require surrogacy is the main focus in order to achieve a family, and how we at Care can support you through that. So as Sam said, I'm Tom. I'm the Medical Director of Care Fertility in Manchester, and a main interest of mine is seeing same-sex couples in general, and I do a lot of surrogacy work. So it's an interest and passion of mine. So it's always a pleasure to talk through the process. So we have a lot of clinics now. So we're the largest group of IVF clinics in the UK. We now have clinics in the USA and Spain as well. So there should be, hopefully, a clinic relatively near you. And sometimes your surrogate might not be near you, but that might mean that she can have her appointments in one place and you can have her appointments in the other, and we can share the information between clinics. We are well known for surrogacy, and we have won, I think, a few times now the Surrogacy Award. And in particular, for example, Manchester and our London clinics see a lot of surrogacy patients, so we're experienced in supporting couples using surrogacy. So the first part of many gay couples or same-sex male couples' journey is choosing an egg donor. And this involves, you can use Care's egg bank, and we have a frozen egg bank. So these are patients that have altruistically, so they've donated their eggs kind of out of the goodness of their own heart. They've not done it for financial gain. They don't get very much money for it. They've donated their eggs and then they're frozen. So they have an IVF cycle similar to what a patient would normally go through, so with stimulation drugs, and those eggs get frozen. Prior to that, I should say, is that these egg donors are all screened. So they're screened for common infections, but also major genetic problems or things that might be common in their particular ethnicity. For example, cystic fibrosis, sickle cell, things such as that. So all of those factors get screened out, and we also do a full medical assessment to make sure that they're fit and healthy and there's nothing concerning in their family history that might prohibit them from becoming an egg donor. So once they're screened, they go through this process, they donate their eggs, and then we freeze them for future use. And the advantage of that is, in comparison to what some of the clinics do, is that when you select your eggs, you know that either kind of that set of eggs is guaranteed in terms of the number, but also that you don't have to wait until that patient is going through stimulation to receive those eggs. So it's logistically a lot easier to organize than fresh donation. So once you've selected your eggs, now in the UK, with the selection of the eggs, unfortunately, it is very limited in the information that you are provided with in order to be able to select an egg donor. So the main things are hair color, eye color, build, ethnicity, skin color. Blood group is also available. Now, in other countries, unlike the UK, it may be what's called anonymous donation, whereas in the UK it is non-anonymous donation. So what we mean by that is when a child is 18, they can contact the HFEA and find out information about their egg donor. So they can find out identifiable information about their egg donor. Now, for same-sex couples, for gay couples, this doesn't come as a big surprise necessarily, because I suppose the children born and conceived with a same-sex male couple, it will always be obvious that it's not genetically one of their offspring. Whereas for straight couples, this is always a little bit more of a kind of an issue or a sticking point that they like to talk about in counselling. But I do think it's often, I've never seen a gay couple that have a concern around that, because it's just known to be part of the process. But that is just the difference with the UK law and how it is non-anonymous. Other clinics, and for example in Spain, it is completely different. So you can have anonymous donation, and you can find out more information about the egg donor. So you then would select these eggs, and then between selecting the eggs and then starting the treatment will depend on all your checks being done and having your surrogate ready, but generally that takes about 6 weeks. There's a long lead up prior to that, which I'll go through in a second. So in terms of the selection process, it's relatively straightforward, and then your eggs could be anywhere across the UK, so then they're shipped to us, and then you're able to start treatments and create embryos. So there is 2 types of surrogacy. So there is direct surrogacy and host surrogacy. So host surrogacy, by far the most common. I've never actually treated a couple with direct surrogacy where they are using their own eggs for the treatment. Most commonly it's host, where you're using donated eggs and one of the partner's sperm. In direct surrogacy, you might be doing IUI and stimulating the egg to be released, or you might be using kind of the surrogate's own eggs to stimulate in an IVF cycle. Finding a surrogate. So you've got your egg donor, hopefully, and now we're on to finding a surrogate. And now this is the process that can be, and I'm sure you all know on the call already, this is the process that can be really challenging. Not always. Some people are really lucky, but in general, it can take a long time to find someone who's willing to kind of support you in creating a family in a surrogacy arrangement. Now, there's lots of ways that you can find a surrogate, and often they're supported by charities. So the main charity in the UK is Surrogacy UK, and there's a few others there. I would just do your research into each of the charities. The main 4 are on the slide there, and they do, even though they are charities, some of them charge pretty hefty fees. So it's just worth looking into it before committing to certain ones. They do have often Facebook groups, or you can find Facebook groups where people can meet surrogates, and often there's events and things like that where you can meet a surrogate. Now, legally as a clinic, we're not allowed to support you in that process. We can support you with the information you need to know where to go, but we can't match people to surrogates like they can in the USA. So you would have to come to us, and the surrogate has to phone us and tell us, I want to be a surrogate for X, and give their details, and then we can match you on the system. And that's generally how it works. So once you've got a surrogate, the process really is twofold. So you and your partner would need a consultation, and we need to look at whoever's providing sperm. You might be interested in both, might be just interested in one. We'd need to do a semen analysis and do a full clinical history, talk about the process in a bit more detail than today, and just really have a chat about what it is exactly that you're wanting to do and wanting to achieve, and how we might get there. So that's from the male partner's point of view. And then from a surrogacy point of view, why it's a little bit more complex than kind of a standard patient using their own gametes and carrying the pregnancy themselves, is that we need to ensure as a clinic that that pregnancy carried by that surrogate, one, is going to be a safe pregnancy both for mum and for your child or your child to be in a surrogacy arrangement, because not all surrogates are suitable candidates for surrogacy. So for example, at Care, we put a limit on the age of a surrogate at 46. So you have to have delivered by that point. And that's because we know, for example, the mortality rate, the complication rate is significantly higher beyond that threshold in pregnancy. So we want to make sure that we're doing the safest thing to make sure that whoever's carrying your pregnancy is the best for you. So the surrogate will then have a separate consultation. We go through their medical history. If they are married or if they're living with someone, they're in a relationship, we usually recommend that they also come for the consultation, because it is a big thing that they're getting involved with. And they also need to understand the implications and what the process involves. And then with the surrogate, we will generally go through the medical aspects of the process and kind of medically what that looks like for them. And in general, what a surrogate has to go through medically is relatively straightforward. So typically we're just preparing the endometrium. So we're not simulating their ovary. So we just prepare the endometrium with either estrogen tablets or in a natural cycle. And we use the patient's own hormones to build up the lining, so we don't give them anything. And then we plan the transfer around their ovulation. The other part of the process is counselling, and you will notice, you're probably already aware that there seems to be a lot of steps in this process, and there are a lot of hoops to jump through. It's a particularly frustrating process no matter where you have your treatment, and that's just because of the legislation around surrogacy. So it is a legal requirement for both the surrogate to have counselling with their partner if they have one, the intended parents, which would be you, and then again all three together. And then once that's complete, and if there's no issues, then you can proceed to treatment. So creating your embryos. So we've talked a little bit about the initial consultation with you guys, and then we talk about how we're going to create the embryos. So we do that with IVF. So we've got your donated eggs in the lab now, and the key thing really here before this process, and the thing that adds a bit more delay, is that you need to quarantine your sperm. So we need the sperm in the lab for 3 months before you can start creating embryos. And that's because, again, a bit of legislation around infection and screening of gametes in embryos prior to them being received in an IVF lab. So we do those blood tests for all of those infections, such as HIV and hepatitis, in all couples. Doesn't matter what type of treatment that you're having. The screening tests in a surrogacy arrangement are a lot more involved. So rather than just the basic, we also do extra infections that we test for. And that is because we know that those embryos you're creating will be going into someone else and not a partner. So it's the law that we have to screen those embryos more extensively. So your blood test will be a little bit more extensive. You have that at the start. You do a sperm freeze, so you bank some sperm, and then you repeat them 3 months later. And the reason for that is that you may have a HIV infection, for example, which doesn't show in the initial results, but then does show in the subsequent results, because it takes a while to show in blood tests. So that's the reason that the UK government has set this rule of delaying by 3 months before you can start to use those gametes. So you've been through that process. You've got your sperm. As I said before, you've got your eggs. We're now going to fertilize them. So if they're frozen eggs, then we do ICSI, so it's a sperm injection, and you have to do the sperm injection with frozen eggs. And the important thing to realize at this part, and this is all the clever stuff that happens in our labs, is that you've got your eggs at the start, and the number of embryos that you have at the end is significantly different. So typically you would expect about 80% of your eggs to survive the freezing process. 80% of those that survive would normally about fertilize, and then about half of those would form an embryo 5 days later that we can use in treatment. So all of this process between us mixing the sperm and the eggs together to then having a transfer, that lasts 5 days. And then we would, in that time, be preparing the surrogate's lining if you were doing it in a fresh cycle, whilst you're having that process done. Or the other alternative is that you may not have a surrogate yet, but you create embryos and then you freeze them prior to a surrogate even being involved, which is what lots of couples do. And it does help in many respects, because if a surrogate knows that you've already got embryos created, they're good embryos and you're good to go, all you'll need to do is have a surrogacy consultation and counselling and then start the treatment. You as a couple will be much more attractive, for want of a better word, to come and be a surrogate for, than someone who's not even started that process. So I would think about that. The other thing, I think there is a slide on extra things that you can do in IVF to help with your success rates, but one of them is biopsying embryos, and I'll come to that, I think, in a second. Legal advice. So legal advice is important, and it is definitely recommended, and Care will only allow you to have treatment once we're assured that you, as the intended parents and as wanting to start a family, we need to be assured that after the treatment and after the delivery of your baby through a surrogate, that you will become the legal parents of that child. And the way that we assure ourselves of that is through the legal advice that you receive, and often contracts are drawn up, and the legalities around surrogacy is complex. The law is completely outdated. It's been under review now for a couple of years, and is probably going to be ready soon for its revision to be released. But essentially, the key is any woman who delivers a child is the legal parent of that child, and that's what the law states. So it doesn't matter whose gametes or embryos, sperm, eggs, it doesn't matter who created that child, the mum is always going to be, the legal mother is always going to be the surrogate. And if the surrogate is married, then the partner will be the legal father. So you can see how it's frustrating, and it is outdated, and as I said, it's being updated. But because of that, you need to have really good legal advice. The solicitors can help you draw up contracts. We have, it depends where you are in the country, but for example, at Manchester, in my clinic, we work with some really good solicitors who send really nice and clear documents and guidance. You can draw up contracts as well. Now, the important thing is that the contracts aren't actually legally binding in law, but should anything happen, of course, you would have a really good chance of fighting the case. Now, touch wood, and I'm glad to say that it's really, really rare for a surrogate to go through all of this and then choose or try and fight to keep your baby. And that is, obviously, it's a really anxious thing to even think about, but it is extremely rare, and Care would do all we can to support you with fighting that, should that happen. But that's why we want all of these things in place, and we want to see the legal advice that you've received before you start. Sperm sharing. So as I said before, you will quarantine your sperm for 3 months. In that 3 months, what some couples choose to do, and this is probably why it's really common, or more common, I should say, in homosexual relationships, gay men having treatment, because you've got that 3 months where you can't do very much with your treatment anyway, and many choose to become a sperm donor at the same time. The advantage is that also surrogacy treatment isn't cheap. It's not, it's no secret. So you do get some money off your treatment if you choose to sperm share. So it depends on your clinic as to how much you get off. So you just have to ask for your fee schedule, and then if you search your fee schedule for sperm sharing, it tells you how much you get back. So in my clinic, it's £3,000 that you get off your treatment for becoming a sperm donor at the same time. And then, of course, you would need appointments with the donation team to go through becoming a sperm donor, which is very different appointments and information that you'll need to receive. And you can also just ring us up when you're in treatment if you're deciding to do this, and let the Care Pals know, and they'll book the appointments for you. So our Care Pals are our admin team that support you with appointments and things like that. IVF we've already touched on. pre-treatment tests. So we've also mentioned semen analysis and then consultation. So I'm just going to skip ahead with this part of it. IVF process. So with the process, really, I've said before in terms of the drop-off rate. So if you imagine an inverted pyramid, and at the top you've got your eggs, your donated eggs, and then through each process, each of those 5 days, you get to the bottom and there's much less of what you've got originally. And that's the key take-home thing. Some people do very well, and actually they get lots of embryos at the end. The embryo at the end is called a blastocyst, and that is essentially what we want to create an embryo. So you've got two parts of a blastocyst: the inner cell mass, what that is, the thing that becomes the baby, and then surrounding that is the placenta. And not the placenta, the trophectoderm, which becomes the placenta. So what we do in IVF is, I'm just going to skip to this part of it. So what we do is we watch an embryo as it develops. So here you can see our CareMap system. So you can see on the slides here, what this is doing is it's videoing the embryo throughout its development. So right from fertilization to it becoming a blastocyst 5 days later, it's videoing in that, and then it analyzes that video and tells us which is the best embryo. So it gives each embryo a score out of 10, and 10 is the best, and then 1 is the worst. So it gives us more information about your embryos, and then we know which one to put back into the surrogate first. Okay. The normal way without care maps is to just look down the microscope, and we just have a look at one of these images, and when we've seen those images, we then grade it how it looks down the microscope. So and then that is a static assessment. So all we're looking at is how it looked. We have no idea how it looked 3 days ago, 2 days ago. We just look on day 5 because we leave it in the incubator, because we know through research that the worst thing you can do with embryos is keep taking them in and out of the incubator. So we just leave them. And that's the idea and the benefit of care maps, is that you don't need to take it out to have a look at it. It's always being monitored, and we therefore get more information. Or we just, as I said, leave it to day 5. We have a look how it looks. We put the best looking one back, and then we freeze the spares. So this is the care maps system. The alternative to that, and probably the best way of selecting the embryo to put back, is PGTA. So this stands for pre-implantation genetic testing for aneuploidy. So PGTA is something that I would do if I was a patient and if I was in your shoes. And the reason for that is, first thing is, in terms of if you've not got a surrogate, a lot of the surrogates will know about PGTA already, so they'll have an idea that this is something that is beneficial for them. It reduces their chances of having a miscarriage and increases their chances of having a successful outcome in most patients. Okay, so PGTA is useful. So how it works is, you can see it here. This is a little biopsy kit on the right hand side. The cells are being taken from outside of the embryo here. So the bit that becomes the placenta, we take about 3 cells, and then those cells go off to a lab, and they tell us whether that embryo is genetically normal or not. And the reason that this is so effective is that even in egg donors, about half of the embryos that you create in egg donation, so in someone who's less than 36 years old, about half of them will be genetically abnormal. So if you're in a position, hopefully, of having quite a few embryos at the end, this is really just giving us the idea of which one is the best one. So why would you, particularly in surrogacy arrangement where time is expensive, treatment's expensive, then why would you spend time and money on an embryo that you could be putting back that is genetically abnormal and could never result in a pregnancy? And there's a 50% chance that if you didn't do this, that's what would be happening. And as I said, because we know that PGTA reduces the miscarriage risk, because we know that we're not putting an embryo back that's chromosomally abnormal, lots of surrogates also like it and are more interested in a partnership, in joining a team, if they know that the embryos that you've got are chromosomally normal. So that's something that I would think about, but it is an additional part of the process. So with PGTA, the results take a couple of weeks. So this is best done with your, not involving your surrogate straight away. So this is best done in creating your embryos, biopsying them, and then what we then do is we freeze them. So that is safe. So 98%, it's very unusual for an embryo to not survive the thaw. So 98% of embryos survive the freezing process. And then we thaw the ones out that are, or one out that is genetically normal, in a subsequent cycle once your surrogate's ready. Okay. This is the freezing process, and as I said, any spare embryos are frozen, and the thaw rate is very good. Now, the transfer is a really nice point to get to, and particularly I think for you guys is compared to lots of other couples, you really have to go through a lot of hoops, a lot of appointments, perhaps even a lot of frustration in finding a surrogate and so on, before you get to this point. So it's a really nice point to get to. And you can both usually come in for this appointment with your surrogate. You can watch the process happen on the screen, as long as she is happy, of course. And how it works is we find the neck of the womb like a smear test, and then we thread a small catheter through the vagina, through the neck of the womb into the uterus, and we use an ultrasound scan and make sure we're putting the embryo in the right place in the uterus. Okay, so you would probably expect a clinical pregnancy rate of about 45%, and a live birth rate of 35 to 37%. We have a pregnancy rate in many of our clinics of around 55% to 60% with biopsied embryos. So it is significantly higher. Now, the alternative is IUI. Probably IUI is mainly used in same-sex female relationships. We would be using the surrogate's eggs in that, so we're stimulating her cycle, timing the IUI correctly, and then we're putting one of the partner's sperm back at the right time of the cycle. So it's really not very common, so I won't spend too much time talking about it. Now, the other options for donation, this is for sperm donation, so I'm going to gloss over this because the key point is really with surrogacy is that one of the partners, one of the intended parents, has to have a genetic relationship to the child, so it wouldn't be relevant. I talked about. So support, now we do have a really nice and lovely surrogacy team, so they work as a team but across our whole group, and they will be your point of contact. Now, if you're wanting surrogacy in particular and you're interested in this part of the process, you can contact our team today with the contact details you've got on the chat, or on our website there is a special section for surrogacy, and you can fill that in with all of the details. One of the surrogacy team, one of the nurses, will get back in touch with you and then book in an initial appointment, which is you don't pay for that appointment. They'll go through your history, the next steps, and you can gain advice from them. And then after that, you then have your consultation. We have an app called Salve, which helps guide you through your treatment, and it's just mentioning that hopefully that makes the process a bit more easy to stay on top of. And I'm going to check over these points. And we do have counsellors that are available to support you at each step. There are also on our website a few different other places that you can get support. So there's care forums. Our social media channel has links to these, as well as our website. So it was a bit of a whistle-stop tour. Any questions with kind of the process? I don't know whether anyone's managed to ask any questions so far. Just have a look. Oh, sorry, apparently there was a problem with my internet connection. So with the pregnancy rates, so there is slight variability, but in general, and it's relatively consistent across different clinics. In a egg donor cycle with a surrogate, you probably would expect a clinical pregnancy rate of about 45%, and that would go up to about 55 to 60% if you'd biopsied the embryos. And there's just another question: do we have an egg bank supply in the UK from clinics abroad? No, in the UK where sorry, this appears to be an issue with my internet connection. But you can, if you're wanting to have treatment in Spain, you can speak to them directly. Right, so there's no more questions, and I seem to be having issues with my internet. But if there is any questions, then please just message the team, and I'm more than happy to reply for you and get back in touch. Okay. And I wish you all the best with you. Said any questions, well, I'm more than happy to, of course, look after you as a consultant. Okay. Thanks for joining, everyone.